Well, that's a very nice setup, and it feels a little odd to be talking about a wired network in this group, but I hope to bridge the wireless and the wired in this. And what I really want to do is talk about the California Telehealth Network as a resource, as a laboratory that is being built for all of you. I want to talk a little bit about how it integrates into telemedicine, and then how body sensors roll into this, and then I'm going to try and pull it all together at the end. So basically, I'm going to talk about the rationale, I'm going to talk about the network, I'm going to talk about some levels of care where body sensors and telehealth can be used, and again, the roles of body sensors. Right now is a critical time, at least in this country, for health care. There is not only is there a movement to make significant changes in our healthcare system, but the current administration has a strong belief that technology is key in that transformation of our healthcare system. And at the same time, we have this explosion of new knowledge. The holy grail sort of in the reform of healthcare in this country is increased access, decreased costs, and increased quality. And the problem is, as we're increasing science, and that's happening all over in research universities where new medical science is being developed, new ways of treating patients are being developed, that's actually creating greater disparities in healthcare, because as quality goes up one place, relatively it's less in another. But what we have said for many years here is that technology, advances in telecommunication and information technology, can help redistribute healthcare information and expertise to where and when it's needed, which is very critical. And that these technologies can help facilitate a new, more efficient model of healthcare across the economic and geographic spectrum. The problem is, and it's, we've all been doing this, is that we, particularly in this country, have tried to just apply these technologies to a broken healthcare system. Rather than create new models of care, new service models, new delivery models using the technology, rather than just saying, okay, we can attach this to our current model of care. So this goes, and it was a wonderful, wonderful talk preceding this, that, the point is that if we just apply the technology to the same model and don't deal with the policy issues, the regulatory issues, etc., we aren't going to see the full potential of these technologies. So, again, and this is not saying wired or wireless, but in general, one of the things that we believe for a technology-enabled healthcare system is widely distributed broadband connectivity, which is reliable, which has explicit quality of service, privacy, and security. As Paul was saying, the FCC, the previous chairman of the FCC, had this program, the Universal Services Fund, which accumulates a lot of money. It's a tax on your phone bills. They've accumulated almost $500 million, and the way they distributed that money was through a very difficult application process. They decided to try and create a new model where large entities could get grants and utilize these dollars, which these dollars were supposed to subsidize the cost of broadband to very remote areas. And so they did this pilot program, and actually there are 69 of these programs that got funded, although we're the largest single state project. And the vision of this was a digital highway for healthcare. And there were a number of people working on this program, but the governor's office said we're going to do one application from the state of California, and all these groups were pulled together to talk about how we would do this. And time was rolling on and on and on, and it was getting closer to the deadline, and they said, okay, well, let's let the university be the applicant. And then time rolled on, and the University Office of the President said, Davis, why don't you, UC Davis, why don't you guys write the application? It were a lot of weekends and nights, but we did turn in an application. It was successful, and what we wanted to do was create a statewide broadband network dedicated to healthcare with explicit quality of service, privacy, and security, to link to national backbones like Internet 2, to leverage and build upon recent investments in telehealth. I won't talk about it except to mention it here. There was a bond passed in November of 2006 that brought $200 million to the University of California for education programs specifically around telemedicine. Those bonds are still hung up in the state budget, but some of those dollars are being released. But the point of this grant was to leverage upon that. Most of that was for buildings and equipment. Also to utilize this network for ongoing disaster preparedness and training. What we told the FCC in our proposal was we were going to extend broadband to 300 plus rural connections. We're to do telemedicine and continuing education. Some of the technical highlights is that we wanted persistent IP-based connections, no dial-up, dedicated end-to-end connections that didn't go out to the public internet, at least within the network. The whole network does connect out to the internet. Explicit quality of service, bandwidth to exceed current needs, so bandwidth on demand, so expandable bandwidth. A rural hospital that's doing video conferencing on a regular basis may 3 times a month want to do, again, in the future, robotic surgery. So they may need expanded bandwidth for a period of time, but they're not going to use that bandwidth all the time, so we wanted that built in. We wanted it interoperable, so peer-to-peer, any-to-any, anybody could go anywhere on the network, monitoring, secure, private, etc., hooked up to the academic centers in the state, etc. So our award was $22.1 million from the FCC. We received, there's a required 15% match. We received $3.6 million from the California Emerging Technology Fund. And we also received a $5 million commitment that's not on here from the United Healthcare for this project. Our original goal was 319 sites, as I said. To have a site qualify, they need to send me a letter of agency saying you can apply for federal funds on our behalf. We were shocked that we had 1,000 locations represented in this. And we've now qualified 860 sites through USAC, which is the Universal Services Administrative Company. We have the RFP being reviewed right now. And I just want to show you that the FCC was right. This was the old program in 2004, how many sites were in California in their program. By 2007, under the old program, this is what happened. With our program, this will be the sites in California that will be connected, and some of those represent up to 14 sites. So you can see it's fairly broad coverage. Now, the other thing is the way we've done telemedicine in the past is often point-to-point connectivity. So there's a hub and there's a spoke, and it's a patchwork of telecommunications. Some ISDN, there's a little bit of DSL in there, there's T1 connections that we run video over IP, etc. That's the way that looks. Under the California Telehealth Network, it's an any-to-any, peer-to-peer, which can connect to anybody. And when we build out this network, you can actually create networks within networks on this within the California Telehealth Network. The other thing is, and I'm not advertising for anybody here, I just chose an example, AT&T and other people have this, but the other piece that we're building into this is seamless integration of wireless devices into this virtual private network, which is going to be very critical for what you all do and what we're talking about here. So it's critical that we have seamless integration of wireless devices into this network to all these essentially 1,000 healthcare clinics and entities. So I'm going to talk about very quickly just sort of some levels of care: disaster preparedness, care in the hospital, in the outpatient setting, and in the home and in the community. So one of the things that we want to do in this network is help in disaster preparedness, and I'll talk about how we do that in a minute. But first I want to talk about why body sensors and personal and small devices are going to be very important in this. At a disaster site, when there's a disaster site, there's a train derailment and there's hundreds of victims. One of the things that we're working on in a project that Dr. Siddiqui is doing, and I'm sure at coffee he'll be glad to talk to you about it, is RFID tagging equipment and people. So we know where the equipment is, but we also know where the patients are. But those patients who have all had various levels of trauma need to be evaluated frequently. And it's very inefficient for emergency personnel to guess which patient's going to go bad when. With body sensors, it can make those emergency personnel much more efficient. And that information can flow into a command center. With the RFID tags, it can tell you what patient is starting to get an increased heart rate, where they are, what patient is starting to drop their blood pressure. Right. Even in the emergency room setting, local telemetry, so the wired telemetry in hospitals are going to be at capacity because they're going to be overwhelmed. And so there are similar issues to the disaster site where they're going to need to have people being monitored, and they're also going to have alarm systems telling when somebody is going bad. And I think that one of the things that we found in some of our telemedicine work in the ICU is that by creating these algorithms where you can combine certain types of physiologic data, if you can simultaneously measure an increasing heart rate and a slightly lowering blood pressure and a falling pulse oximetry, that can tell you earlier that somebody is going into shock. And so those kinds of things are going to have to be integrated. So it's not just the one-off kind of monitors, but it's going to be connecting these body sensors together and have smart interpretation of several lines of physiologic data at the same time. One of the things we also believe is critical out to remote hospitals. A train derails in the rural part of California and you're doing all this stuff, but we also realize that they lack sufficient numbers of medical specialists and personnel. They may have beds and they may have equipment, but they don't have a burn surgeon, they don't have an infectious disease person in a pandemic, etc. And I think that telemedicine, aided by these monitoring devices, you could have physicians seeing those patients in remote areas, aided by, again, monitoring devices, body sensors that could help bring expertise to the point of care. So what about care in the hospital and emergency room setting? I think that most people think in the non-disaster setting there probably isn't much because we already have a lot of wired as well as wireless telemetry and those kinds of things. But I think there are some opportunities. I show you this picture. This is one of our pediatric critical care doctors seeing a pediatric patient in a rural hospital. And we do this in a number of hospitals around the state where we bring expertise into the small rural hospitals, and the pediatric sessions have been extremely valuable and successful. And again, in that kind of a setting, they can see the current types of telemetry systems, etc. In the hospital, but in the hospital setting today, people are much sicker than they've been in the past. They need expertise 24/7. And access to a specialist is often much more challenging in small hospitals. We found that telemedicine, and Dr. Siddiqui has been involved in bringing infectious disease expertise into small hospitals that don't have infectious disease doctors, and that's been extremely valuable. And so a lot of people say that hospitals already have this body monitoring down, but in reality, I think that body sensors can play a role in hospitals. One of the biggest challenges we have in hospitals that we worry about are falls. Patients start getting better and they want to start ambulating the halls, and so we tie up a nurse to walk with them because we don't know who's, we try and grade who's at fall risk or who's not at fall risk. Some of the devices, and I'm not going to steal the thunder of the people that are going to present it, but some of the devices that measure gait and the gyroscopes and all those kinds of things can help with that. I think in some small hospitals we can do remote rehab. These are devices that roll around the halls, one robotically controlled. Imagine a hospital that doesn't have a physical medicine rehabilitation physician, but you're trying to rehab a person from a knee injury, and you're getting body sensor information sent remotely, and the doctor is following the patient down the hall with the camera, can talk to the patient, etc. So I think there are opportunities. Probably not as many, but there are clear opportunities. So healthcare in the outpatient setting, and in this I'm going to weave one other thing into the mix here besides telemedicine and body sensors, and that is electronic records. We really think about that there's really two kinds of information that's critical to make healthcare decisions. One is information about the patient, so current, complete, accurate information about the patient. And the second is the medical science that's out in the world that applies to that patient. And so those are the critical things that we need. In terms of information about the patient, what we need is their history, their past history, review of systems, meaning how's their eyes, nose, throat, etc. Their family history, social history, their medications, their allergies, their physical findings, their current and their past imaging, and laboratory work, etc. And soon, tons of information, which is going to be a real challenge for hospital systems, is as we move towards personalized medicine, as we prescribe drugs based on your genetic code, we're going to have much bigger records for patients to store all those data. Electronic health records have been designed for these purposes. They can lead to disease registries on patients. Some have built-in decision support. But the other kind of information, which I talked about, is the healthcare information that still needs, that the providers need access to, which is state-of-the-art knowledge, which is why telemedicine is important. Telemedicine brings expertise to the point of care and allows it to be customized to that patient. We are aided in that, obviously, by a number of devices. Handheld devices, we look down people's throats, we look in their ears, we have one-chip, high-resolution cameras. But one of the things we haven't done is apply body sensors in this process as much as we could to aid us in telemedicine. I'm going to show you a video here for a second.
There are lots of reasons people leave large metropolitan areas like this to live in rural communities like this. But when there are special medical needs to consider, living in small towns can mean big drives.
Well, we live in a remarkable state in which patients come to me from southern Oregon, from middle Nevada, from the center of California all the way to the coast. People can travel to see us 7 hours on some occasion, one way.
Dr. Dennis Stein is a pediatric endocrinologist at the UC Davis Medical Center. He knows the difficulties families face when traveling long distances to receive high-quality, specialized care for diseases like diabetes.
Last time we saw her, hemoglobin A1C was 10.
But all that's changing thanks to the expanding world of telemedicine. Now, coordinated care from one home base or a medical home is as easy as making a phone call.
How can we bring the medical home to some of the smaller towns a few hours away from here that have a population that isn't conducive to setting up all these specialists on their own site. Well, we can use telemedicine, and we can use all the expertise of the environment that we have here at the medical center and bring it to the smaller centers and provide a medical home for the child in the smaller towns.
And I see 278 this morning.
In this telemedicine consult, the specialist, Dr. Stein, is in Sacramento,
Do we have any noontime values?
while 15-year-old Sarah, her mother, and her primary care doctor are 90 miles away in Oroville. Sarah's diabetes has been out of control for some time, but with their busy lives, getting down to Sacramento to see a specialist has been impossible to schedule. Now, for patients who can't come to the big city, telemedicine brings the big city to them.
So your body is not real happy with these numbers. We have to figure some way to get them down.
Both the doctors being together at the same time, being able to discuss Sarah's complete health is a relief to me.
It makes me a lot more healthier because I have more doctors looking out for me, one here in town and in Sacramento.
Were you able to get any blood sugar while he was having this behavior?
The medical center has logged over 1,000 telemedicine consultations with specialties from otolaryngology to fetal monitoring. Now in California's rural communities, easy and accessible medical care is just a mouse click away.
It's not quite the personal contact of a small room, it's true, but with a motivated family that understands how to care for the child and wishes to do so, it's an ideal situation.
Thank you.
So that video was done 10 years ago, almost 10 years ago. We still are doing things the same way. You several times you've heard in that, what was there, did you get a blood sugar at noon? What was that? Did you have blood sugar? Did you have a blood sugar during that behavior? Do you remember what the blood sugar was during that behavior? We should by now have continuous blood sugar monitoring, or at least intermittent blood sugar monitoring of patients, so that that doctor, when they're seeing the patient, can say, during this time, I noticed this is what your blood sugar has been doing. I can see it from the data that's been sent in by your blood sugar monitor that you wear. And so we need to develop devices like that to help us. Traditionally, we've used the same process for managing chronic disease as we've used for managing acute illness. And I'm going to show you another video here.
Good morning.
How are you feeling, sir?
I'm feeling good. A lot better.
J.L. Atterbury is a participant. He was diagnosed with lymphoma 3 months ago. J.L., assisted by his wife Lynetta, records his blood pressure every day and conducts a self-checkup once a week. A nurse walks them through the home exam and then analyzes the data. J.L. says the machine has reduced the number of visits he must make to his doctor 15 miles away.
I had to use a wheelchair. And my wife, you know, it's a big hospital, and she'd let me out and get a wheelchair, and then she'd have to go find a parking place. So this is wonderful. Much, much easier.
And sometimes telehealth plays a part in early intervention.
It was in the morning, and he developed a chill. So put him back in, or he was in bed, so I went in and I covered him up, and I took his temperature, and it was 100. So I went to the machine, and I called, and they said, well, now to hang up, grab your coat and him, and come on in. So by the time we got there, he was code 1.
My wife has phone numbers. If she wants to call and has questions, she call, and they're there. Even my family doctor, the nurse called yesterday. She said anytime my wife wants to call and talk, just call.
Now, that was 12 years ago, and there's no reason that they had to have a chill, and then she takes his temperature, then she makes a call to say that he has a fever, what should I do? That information for a guy who's at home recovering from lymphoma, his temperature should be continuously being sent to a database, etc. And I think that one of the things that we haven't done is thought about how to apply these things in home health. And just to show you how valuable home health can be, this is a VA study that's more recent. This is a study, their Health Buddy system, again, but this is sort of intermittent kind of contact rather than continuous contact. This is a study that the VA did, and the results in 2002 showed that by being connected to people with chronic diseases in their home, they were able to reduce emergency room visits by 40%. They had hospital days reduction. They had nursing home reductions, etc., and quality of life measures were up. Data from later in 2005 showed outcome data that were impressive. So real outcome data in terms of things like shortness of breath and medication adherence and those kinds of things. So this can work. I would say that if we combined some of these things with body sensors and the home telemedicine, those things would be that would be far better. An ideal situation is having complete information about a patient that is continuously captured in a database for the parameter that you're worried about. And in chronic disease, accurate physiologic data during normal activities, trends are key in that. Patterns of data from multiple sources, as I talked about in the disaster example, and alerts that can alert not only the patient, that can ring their wireless device, their cell phone, but also send information for critical values. So setting parameters on, we don't want a heart rate above this or below this, and if it happens, it should send a signal and call you and tell you, sit down, we're calling your doctor's office, etc. Now, I stole this from Paul, this slide, but this is of how things should be, where they're wearing, functional jewelry, as we've talked about. I guess jewelry may be functional, but this kind of, where somebody has, maybe this guy's wearing an earring or something, but where you have all this information being aggregated into a wireless device, that it's alerting the patient themselves, telling them where they are, but also during parameters that are outside of a range, send to a nurse like the nurse in that video from the Kaiser video. And I think that could revolutionize the way we do chronic disease. And let me just take us back for a minute about just one example, because I deal with this. My father's 95 years old. He has heart disease, and I can't tell you how many times I've gone into the physician or office or the emergency room with him, and we go through this process of this episodic visit where they say, "No, tell me, you've been feeling lightheaded, or can you tell me when it happens, what you're doing?" And he can't remember that. They say, "Well, let's take your blood pressure and your heart rate." Well, it's fine. Your heart rate and blood pressure are fine right now. But what with body sensors, if my dad was wearing, if he had all those things on, they would be getting, heart rate, blood pressure, oximetry, temperature. Hopefully someday we'll be able to get a reliable way to get continuous blood sugar, aggregate that to his mobile device. Again, critical values, would call the doc so they could say, "Okay, we're looking at it right now. Are you feeling lightheaded? I can see what your heart rate is. I can see what your blood pressure is." And again, setting up algorithms that match when trends are going, when heart rate's going up, blood pressure's going down, pulse oximetry's dropping, and even possibly autonomous kinds of treatments. And I know somebody's going to talk about that, but this is a device that Washington University is just reporting on. That's a very small device that is implanted under the skin, and there are electrical signals to nerve receptors along the carotid arteries of the neck. This will actually signal your body's own system to lower blood pressure. So if this is feeding back to a high blood pressure to this device, it can be lowering your blood pressure automatically. So it may not need to call anybody. So how this all comes together. So all patients need a medical home. They need, a place where they get their care. But they need to have electronic health records. They need to have portable health records that really are fully portable, so they can take them anywhere that they need to go. That all providers need to be able to exchange, health information and connect to each other via telemedicine. And body sensors should be used in this new system for chronic disease management, for falls prevention, monitoring the elderly, for wandering off because they have GPS devices connected, for weight loss. I was with my niece this last weekend, and she was wearing something on her arm, and I asked her, "Is that your iPod?" She says, "No, it's my body bug. It's telling me how many calories I'm burning." And so these things are happening. We need to incorporate that. And some of the sensors need to connect with autonomous devices like insulin pumps and blood pressure control devices like the one I showed. Data from the sensors need to flow into electronic health records and into accessible data repositories. And translational researchers, people who are doing clinical trials, need to also be involved in this. This is going to revolutionize the way we do clinical trials for new drugs, etc. So in summary, I think advanced information and telecommunication technology have a central role to play in transforming our healthcare system. Currently, there's an unprecedented amount of financial and political investment into this approach. Body sensors could play a key role in this transformation, and I think the California Telehealth Network represents an ideal opportunity for research and development of these new devices and models of care, because I think it not only gives you a wired environment that people are connected and we can connect them to big computers and databases, but it also represents 1,000 clinics that want to participate in a new model of healthcare. And so I think we have a real opportunity to significantly change the way we deliver healthcare, and a really nice laboratory to do that in. Thank you.
Thank you.
That was a phenomenal talk. Let's have some questions. I'm sure there are plenty.
Over here.
Yes, gentleman at the back.
It was a very nice talk, I must say. And I have a question regarding the way that is the reimbursement done in your country. How do patients pay themselves? If somebody like the gentleman that you showed with his wife is getting a device, how is that done?
So that's the big problem. That's why we need policy change. In that system, that was in our Kaiser system, which is a prepaid system. So essentially, it's an HMO. So patients pay a set amount of dollars, and they get health care. And that system has an incentive to try and reduce hospitalizations. In other reimbursement models in this country, there is no incentive to do that, because we get paid more when they come to the emergency room. So one of the things we need to do is to match up the models of care with the policy in reimbursement, and that's the only way we're gonna lower costs. But in that system, that happens to be a system that incentivizes keeping the patient out of the emergency room. But a good chunk of our patients in this country aren't in that system. They're on a fee-for-service kind of model. Yes?
Thank you. I have a question about, I think for the whole system, the telehealth system, you need to share information between different care providers.
Yeah.
But however, I think in my feeling as a user, I feeling as in U.S., care providers are very hesitated to share the information because of the liability issue. On the other hand, I also see even for other countries like in China, hospital doesn't want to share the information because that means they give their customer away to other healthcare providers. What do you think? How can we break this barrier?
Well, right now there's there's a lot of stimulus dollars coming from Washington for health information exchange. There's going to be in each state, there's going to be a state-designated entity to coordinate health information exchange. The problem is, how do you incentivize people to do that? Well, what they're going to do is they're going to give money for people to get electronic health records, and they're going to try and do it with a carrot rather than a stick. They're going to try and provide, ask people they're going to give people essentially money for new technology if they participate in health information exchange. But it's a huge issue. because you're absolutely right. Some systems don't want to share information with other systems because they're worried that they'll lose patients that way. And so I think it's going to come from top down, from the government is going to require that you have a common set of data.
Jack.
Have you or do you know people who have done any real analysis of the problem of costs dealing with false positives?
I'm not aware of that, but I think you mean from sensors?
Yeah, well, you get answers. You said this guy's in trouble, but he's not.
Yeah.
And that's expensive because you
Yeah,
ethically
absolutely.
have to chase it.
Yeah, and we get that all the time in the real in our currently in telemetry in the hospital where we think somebody's in trouble, and I think that there clearly needs to be research done on that as well, and I think it speaks to the need for reliable systems, but I think that the alternative is also very expensive, and I can. Just from anecdotal information, I can talk about my own patients who end up in the hospital for events that they say, I had an event, I don't know what it was, I think my blood pressure went down, we put them in the hospital and don't find anything. So I think it is a double-edged sword, and I think we need to think about the fact that once we start doing this, we're going to create a whole new set of problems. The question is, can we do it reliably? Yeah.
So just like you, it's a little bit of an open-ended question. So people like Andy Grove and others want to make a distinction between electronic medical records and personal health records.
Yes, absolutely.
And certainly Google and Microsoft are headed in the direction of... So can you sort of paint a picture of what... And in some ways, maybe an answer to the question that was asked is if the ownership of the health record is individual,
right,
that certainly facilitates the exchange. So I'd just like you to just sort of talk a little bit
No,
about
that's
these issues.
absolutely right, and that's a real debate right now. I think when the patient, ultimately the patient should own their record, and then it can go anywhere. Healthcare providers, whether this is a real concern that they need to be concerned about or not, once you have a personal health record and you can put anything into that record you want to put into it, the problem is, will there be too much noise in that record that isn't valuable? In other words, can the healthcare provider rely on the information? And it could be somewhat of an excuse for for exactly what the question was asked, is how do I know that this X-ray report is accurate? How do I know that this doctor's diagnosis from, Kansas is right, that you really do have this disease? And so that's one of the concerns about health information exchange. But I do think ultimately, and I think we're moving very, very fast towards this, is that it's going to be personal health records that are accessible to physicians rather than physician-owned records that are parts of which are accessible to patients. So I think as we move towards personal health records, the problem of who owns the data will be solved, and it'll be available to any provider.
Good enough. Yes, General, at the back.
You haven't spoke about any standardization problem. I mean, which kind of standards do you work with in California, telehealth medicine?
So, in terms of telemedicine, we have standards-based video conferencing. Is that what you're talking about?
No, like HL7 or...
Right. For health information exchange, I think we're moving towards that. We use HL7 for as the standards, but I think there is a huge need for standards in all these areas. One of the things we absolutely have to work on is standards, and not just standards in terms of how the information is exchanged and those kinds of things, but is a 3-inch picture on a cell phone, is that diagnostic capable? I mean, what kinds of resolution do you need? What frame rate do you need to diagnose a gait problem? Is it 30 frames a second or is it 7? You know, so I think one of the areas, and I actually had a slide, but in the interest of time I cut it out, that one of the things that we need to work on simultaneously to this is standards, because the big fear of the payers is that we're going to have very low quality devices, etc., and we're going to be charging them for that. So I think standards is a huge area, and some people are working on it. Radiology has already solved that, you know, with the DICOM standard for transferring images and those kinds of things. But I think the rest of telemedicine, the rest of body sensors, areas we need to work on.
I think we could probably pepper Dr. Nesbitt with questions all morning. I'm sure he's going to be around for a while. Yeah. And his colleague Javid is in the room, and others from UC Davis. So please, Javid, put your hand up again. I think some people trust you. And please ask them more questions and enjoy their company afterwards. But for now, I think another warm round of applause for Dr. Nesbitt.